welcome to our Conversations in Interventional Cardiology series. My name is Alexandra Lansky from Yale. I'm editor-in-chief of JSCAI, and we're here to discuss a really exciting study that's going to be presented at the late-breaking trial session with a simultaneous publication in JSCAI entitled Sex Differences in Clinical Characteristics, Management Strategies and Outcomes of STEMI with COVID-19 from the NACMI Registry. I'm here with a wonderful panel. We have our first author, Odayme Quesada, who's the head of the Women's Health Program at the Christ Hospital in Cincinnati. Tim Henry, current president of SCAI and medical director of the Lindner Center for Research and Education. And we're absolutely delighted to have Mirvat Alasnag from Jeddah, Saudi Arabia. She is the director of the cath lab at King Fahd Hospital in Jeddah. So welcome, everybody. It's really wonderful to have you here. So to kick this off, Odayme, I'm going to ask you to tell us a little bit about your study.
Of course. And first off, thank you very much, Dr. Lansky, and all the panelists for being here with us today. We're excited to be presenting this at the upcoming SCAI conference. So we'll get started. So a little bit of background to get us started with, as everyone on this call knows, prior to coronavirus disease 2019, COVID-19 pandemic, there's been sex differences that have been described in STEMI patients with worse outcomes in women. And although worse prognosis has been reported in males with COVID-19 infection, sex differences in STEMI patients with concomitant COVID-19 infection had not been reported to date. Therefore, the goal of this study was really to describe sex differences in clinical characteristics, management strategies, and outcomes of STEMI patients with concomitant COVID-19 infection. We use the NACMI Registry, as you alluded to. This is the North American COVID-19 STEMI Registry, and it is a multi-center observational registry of hospitalized STEMI patients with COVID-19 infection, and it is prospective in 64 sites, 12 Canadian sites, and 52 US sites. And patients were enrolled from March 1st, 2020 to December 31, 2021. And here are our findings. So we found that among 585 COVID-19 positive patients with STEMI, there were significant differences between men and women, as it's illustrated in our figure. First of all, in terms of the distribution, more patients were males, as can be seen here. STEMI patients with COVID-19, close to 74% compared to 26% of women. In terms of age, women were older, so 65% were older than 66 years old compared to 37% of males. And then when looking at risk factors at the time of presentation with STEMI, we found more risks, more diabetes and more stroke in women compared to men, and that was significant. In terms of their symptoms at the time of presentation, men presented more with chest pain, whereas women presented more with shortness of breath, and these were both statistically significant. And very interesting, when we looked at the culprit vessel in these patients with COVID-19 presenting with a STEMI, 82% of men had a culprit vessel, whereas only 67% of women had a culprit vessel, and that was statistically significant. And it's not surprising with that difference that we found that when we looked at primary and rescue PCI, there was a higher percentage of men that received primary rescue PCI, 76%, as compared to 61% in women. When we looked at medical therapy was higher in women compared to men. But very important and interesting was that despite these differences, the mortality between men and women was actually very similar, 33% in women, 27% in men, but very high as compared to prior to COVID-19. So in conclusions, in the NACMI Registry of patients presenting with STEMI in the context of COVID-19, the in-hospital mortality rate, as I alluded to, was 30% and similar in men and women. The lack of identifiable culprit lesion was more common in the setting of COVID-19 in both sexes, but more likely in women, 1/3 of women versus 1/5 of men. We saw, as I presented, that there are sex differences in risk factors, presentation, and treatment, and we are currently undergoing evaluation evaluation of specific underlying etiologies in order to better define the full impact of COVID-19 on these STEMI outcomes and better understand these sex differences, particularly the culprit lesions. Thank you.
So thank you, Odayme. That was great. And I think the study is absolutely phenomenal. I think there are many issues about this study that I think, you should be commended for. And Tim is the lead PI on the registry. So again, kudos to you both. I think one of the key things here is this, you're capturing patients at the very early stage of the pandemic. And I do think that probably has an impact on the mortality rates that we're seeing, where mortality was much higher at that early stage. And to my knowledge, this is the biggest series, right, looking at sex-based differences. So kudos to you. I think we're absolutely thrilled to have it in our journal. I think it brings a lot of good information. It's benchmarking outcomes, et cetera. I just wanted to kick this off. This is not, and ask you to try and define the patient population a little bit more. This is not our typical STEMI patients that are coming to the hospital, right, for primary angioplasty. It's much more of a broader patient population. Can you talk a little bit more about that?
Yes, absolutely. And Tim can jump in since he's the lead of the NACMI Registry. But you're right. These are patients that are presenting during the peak of the COVID-19 pandemic. And we're still learning more about how COVID-19 affects STEMI patients. But we definitely know that there's definitely an increase in mortality in patients that have both concomitant STEMI elevations and infections. So correct, we do know that the infection itself definitely played a role into the much higher mortality that we're seeing in this registry than we've seen in the past, especially with all the advances. And in terms of the pathophysiology, we're still looking at the angiography core lab to really determine what is the etiology of these STEMIs. But the fact that there was such a high of non-culprit lesions really makes us think that there's other things like thrombosis, especially knowing that COVID-19 is a prothrombotic state. That is definitely something that we're going to be exploring more when we have the core lab data to figure out the etiology, especially of those non-culprits. But very good point.
Number one, the initial report we in the fall of 2020 that we presented late breaking at TCT showed this markedly high increase in mortality that was 33%. And there was a predilection for diabetics and for Blacks and Hispanics that was really unusual. And second of all, we saw that there was a high percentage of people that didn't get cath, mostly because they were too sick, especially this was the initial stages where severe COVID pneumonia. And then second, you saw this 25 to 30% of people had no clear culprit, but they still had ST elevation. So then we recently reported the trends at ACC, and it was also published in JACC, and it showed that there's a big difference between 2020 and 2021. So as we've gotten treatments and as we've gotten vaccines, the disease has changed a little bit. But still, this really interesting thing, what I would call STEMI Minoka, because really think about this. This is patients with ST elevation, positive enzymes, and but yet no clear culprit. And it's a multifactorial group. It includes things like Takotsubo's. It includes things like probably some embolism. But one of the really unique ones that we're really learning more about is this issue about microthrombi, and where it's been reported pathology in multiple different organs that you have microthrombi, and there's a whole series of patients that present with basically slow flow in multiple different coronary arteries, and it's not specific emboli, it's just slow flow because there's no outflow. And the fact that this is much more common in women, just like normal Minoka is more common with women, I think is fascinating. And I mean, think about that. 33% of the women with ST elevation had no culprit. I mean, so this is a really important issue that we have to further investigate.
Right. So to your point, going back to the angiograms and trying to dig into it and understand the underlying mechanism, I guess, of Minoka is going to be really important. Mirvat, is this sort of aligned with your experience?
It certainly was a great registry to look at. And I think what was reassuring is to see that we're still delivering timely primary PCI for these patients as we should. It's nice to capture the trends over time as we're seeing new variants and as vaccinations are being widespread and so on. But yes, MINOCA, as Tim just mentioned, is actually something we need to learn about in both COVID and in non-COVID. And it would be interesting to expand our understanding of MINOCA based on registries such as this. Meaning, if we're looking at microthrombi, should we really be evaluating thrombophilia profiles in these patients? Should we be doing more intracoronary imaging to see if we're actually missing fluoroscopic thrombi that can be picked up by optical coherence tomography? Are we going to be seeing more erosions as opposed to ruptures, etc.? And so I think it's telling us what we need to do. And as this registry continues and perhaps more data points can be collected, it can help us as we move on, because we all recognize that COVID is here and it's here to stay. Perhaps it's changing along the way, year after year. And along with it, we need to adapt and learn how to handle these patients, because they're certainly out there and they are our responsibility.
Yeah, excellent points. I wanted to shift the conversation a little bit about the pathways of care. I think one of the things that COVID did was completely put the pathway of care for STEMI on its head, right? Not just within the healthcare system, but also from the perspective of the patients. And, when I look at these results that you showed us, 20% of these patients actually didn't even have angiography, which probably also contributes, right, to a high mortality.
So that I'll maybe take the beginning part of that. So I think it's a terrific question. And the point was there was a tremendous impact, dramatic impact from COVID, both a direct impact, i.e., COVID patients having ST elevation, as well as an indirect, because we scared people and then there was a reduction in patients actually presenting to the hospital. Theoretically, we should have seen an increase in STEMI patients, but instead we saw about a 40% reduction. And these were not COVID patients, but the consequences of that, we saw more cardiogenic shock, we saw more late presenters, we saw more complications of MI, that it was almost like we moved back 20 years. And so there's so many implications of this. And I think, just to tantalize you, I can tell you it's going forward, because one of the things that Odayme and I have been really interested in is microvascular dysfunction. And so we have a whole series of patients now that after they had COVID, and in particular, I'll give you an example of a COVID STEMI patient. 9 days after having COVID, she presented with an anterior lateral ST elevation and had slow flow in both the LED and the circumflex. Really, 4 different vessels had slow flow. We gave intensive anticoagulation, we did thrombectomy, everything we could. We got it back to TIMI 2 flow. But basically, 3 days later, she finally reperfused and had T-wave inversion. And then she recovered. Her EF was about 45%. And about a month, she was relatively asymptomatic. Well, lo and behold, 2 months later, now she's developed exertional angina, and we just did her coronary flow reserve, and she had markedly abnormal coronary flow reserve. So we think this is microthrombi affected the endothelium, and now she's developed microvascular dysfunction. So there's so much to learn, and we have an angiographic core lab in process, we have an EKG core lab in process, and we now have more than 800, nearly 800 COVID positive patients enrolled. So we're going to keep learning.
Yeah, beautiful. Mirvat, how did, in terms of the pathways of care, I mean, any comments from your side of the world?
So I think it was very much the same. Patients were afraid to present to hospitals, and so we found a lot of late presenters. Unfortunately, after a year or so with COVID, we started to see more heart failure patients. And I think this is shifting now as things are starting to somewhat normalize. We're starting to see our patients back coming in and our primary PCI programs picking up. One thing we have noticed is a lot of vasculitis. So patients who have had COVID and then come about a month later or several weeks later with an acute coronary syndrome, whether it's an ST elevation MI or a non-ST elevation myocardial infarction, and when you go in, you just see ectatic vessels, almost resembling a Kawasaki kind of picture. And you do see the TIMI2 flow and sluggish flow in these coronaries, and just wondering if that is yet another variant of COVID, and we didn't see it early on in the pandemic. So I don't know if it's a different variant of the viruses. I wonder if it's just we weren't seeing these patients, they weren't coming to the hospital, and we're just seeing them more often now. It's a bit difficult at this phase in the pandemic to figure it out, but I'm sure, again, with more longitudinal follow-up, we may start to learn more about vasculitis as well in these patients.
Right. I was gonna comment. I don't know that at this point we would do necessarily anything different. What do you think, Tim?
Yeah, here's what I'll tell you too. I think one of the things I would say to put in a plug for SCAI. SCAI was really on the forefront of this in terms of, number one, developing the NACMI Registry, which is a unique collaboration with the Canadian Association of Interventional Cardiology, as well as the American College of Cardiology Interventional Council. And then number two, we put out guidelines in April of 2020 that basically said, treat STEMI just like you should. Go to the cath lab. And to the credit for the investigators in Canada and US, that's what they did. So these patients, and the ones who didn't have an angiogram at all were really, if you look at them, are really the ones with very advanced COVID pneumonia, who were on ECMO, who were on ventilators. But the patients who had STEMI actually majority went to the hospital and got PCI. There wasn't a shift to lytics or was it, that. And the time from symptom onset to arrival at the hospital was longer, but the door to balloon times were not longer. So that means when you actually came to the hospital, the interventional cardiology community did a tremendous job of actually going to the cath lab quickly.
Great. Last words, I think we're coming to the end of our sessions, but, just how did you pull this registry together and get it going so quickly? I mean, this was, 3 months? I think it was March of, the pandemic. I mean, it's just so impressive.
Yeah, so this is really a testimony to really the, people wanting to do the right thing.
Right.
Because there was no financial support for this. And remember, this was a time when our research infrastructure was incredibly fragmented, right? And so these are sites that while we noticed the reports on social media, so we decided to put the registry together. And within 1 month, we had a protocol, IRB, a central IRB approval, and a paper that was submitted in terms of the outline, the NACMI registry thing. And we're recruiting patients within 1 month and with no financial support. So this was really, goodwill from interventional cardiologists all across who were trying to figure out what was happening and have insights to make our care better. So this is, I think, an amazing story, actually.
I think so too. So congrats to you and the whole team. And I think we're learning, and we're going to continue to learn, obviously, from, this is a hugely rich data set, and looking forward to many more publications in our journal. Anyhow, I want to thank you all thanks Odayme for a wonderful presentation. And thank you, Tim and Mirvat, for joining us today. I think this was a great conversation. Thank you.